Good morning. Uh, so here we are with uh, my continuing talks on old age disease and problems in the old age. And the last video was about colonic disease, large intestine. So I left small intestine. Today I'll be going into the disease of small intestine in old people. So I said small intestinal problems are not that high in old people. It is true, but it does happen. It may not be that common, but it does happen. Intestinal obstruction happens, and intestinal bleeding happens. Then you have malabsorption happens, and some of these problems could be missed if you don't keep these things in your mind. You can actually miss, for example, malabsorption. Malabsorption does not present with, like in younger age with the diarrhea and bloating and all those things, steatorrhea. In old people, they cannot measure the stool fat for steatorrhea, and you will have to do some other test like measuring the lactose intolerance by lactose provocation test or lactose hydrogen breath test. Give lactose and after a certain period, 1 or 2 hours, serially measure the rise in hydrogen breath. So that will measure the quantity of lactose which is not reabsorbed, which is not absorbed. So there some problems are there like this. So the main function of small intestine is absorption. So the main disease also malabsorption. The absorption is not taking place. All the things are absorbed through the small intestine: fat, protein, carbohydrates, and vitamins. All these are absorbed in the small intestine. So when there is a malabsorption, these things may not reach the body. May not manifest overtly like in some clinical cases, but old people who have a lot of debility and they have this one osteoporosis or penia, and they have low vitamin D and low vitamin B12, causing megaloblastic anemia. Megaloblastic anemia in old people is not due to the this defect in the intrinsic factor. Most of the time it happens in the intestine, in the stomach, because the stomach acid is low, so it cannot decouple the vitamin B12 for the food, so absorption will not take place. So it will produce subtle clinical manifestations, like they will have they can have some kind of neuropathy, and it adds to a dementia, like that, and loss of weight. Of course, if a lot of carbohydrate is lost, then they will have a lot of diarrhea, things like that. But that does not generally happen. Diarrhea, steatorrhea may not be that common, but reabsorption of vitamin B12 is impacted, as well as this one vitamin D, and along with that the calcium absorption is less. So malabsorption you always have to keep in mind. There are specific 2 or 3 reasons for malabsorption in old people. The most common people would say is the celiac disease. I wonder whether any of you have had an opportunity to diagnose celiac disease. it may not be that uncommon, because celiac disease only 30% will be symptomatic, 70% is dormant. Mm. So it's you have to make an active diagnosis, in the sense that if you suspect celiac disease, you have to do a few tests like serology. The celiac disease, by the way, is an immune disease. It's not an autoimmune disease. It's an immune disease. It has got this immunoglobulin A is attacking this one the intestinal villus structures. So you can measure what's called IgA endomysial antibody level. So that's one serological test. Then, of course, how you clinch the diagnosis is by taking a biopsy from the upper intestine. Upper intestine biopsy means the duodenal biopsy, but if you introduce what's called an endoscopy, there is something called a push endoscopy. You can get a biopsy from the jejunum also. And in the biopsy, you'll see there will be villus atrophy. Then there will be what's called crypt hyperplasia, crypt, that in the intestinal crypt, as well as infiltration, lot of infiltration by the lymphocytes in the epithelium. So these three things are the histological diagnosis for which. So histological diagnosis has to be there if possible, but may not be positive in all cases. It depends upon where your sampling is, because celiac disease need not be generalized. It can skip areas that can be there. So it's the diagnosis is a combination of serology plus this thing plus clinical. So if you get a diagnosis of celiac disease, the celiac disease is most often caused by the body reaction to particular food antigen, especially in cereals like wheat. It's called gluten. So if you diagnose celiac disease, put the patient on gluten-free diet. The gluten containing diets of wheat, all these cereals. But a gluten-free diet is a particular kind of wheat is that. It's called bulgur wheat. Bulgur wheat, then all is our millets may be free from this thing. Even oats is free from. So I've substituted all these things for wheat, and rice, brown rice is free from gluten. So as far as we are concerned, probably that's why gluten and enteropathy, this celiac disease is not that common in some parts of India, because most of us eat rice. So that's one cause for malabsorption. The other common cause is what's called the bacterial overload syndrome. Intestine, colon, everything has a lot of bacteria. The difference from intestinal bacteria and colon bacteria is intestinal bacteria tend to be mostly aerobic. But as you come down the intestine, reach the ileal part, the lower part, it can have a combination of aerobic and anaerobic. Colon, of course, is completely anaerobic. So when there is the increase in the anaerobic content of the intestine, malabsorption will take place. This anaerobic bacteria will again inhibit the bile salts and produce bile salt, produce diarrhea and all those things. And malabsorption can also take place. So then iatrogenic. Sometimes there are not iatrogenic. Sometimes maybe you have Crohn's disease and there is a fistula between upper part of the intestine and lower part. Then again there is a anaerobic invasion. of microbacteria. And another way is there can be diverticula in the intestine that can also stay. Any stasis, also there is a structure which produces stasis, they can produce bacterial overload. The bacterial overload will produce a lot of changes in the intestinal content, and the absorption will be low, and so they'll get malabsorption, especially malabsorption of B12, malabsorption of this one vitamin D, just like Crohn's, vitamin D, and calcium and all those things. It involves more of the ileum. So the bacterial content can also be measured. If you take a sample from the upper jejunum by endoscopy, you can measure if the colony forming bacteria is more than a million per ml, then probably there is a bacterial overload. So that's the diagnosis of bacterial overload. So these are the two common causes: celiac disease and bacterial overload syndrome, which is the reason for malabsorption and debility in old people. In old people can be quite subtle. They will present with falls, they will present with loss of weight, they will present with disorientation, they will present with even epilepsy. By the way, there's celiac disease also, even though it's an immune disease, it's associated with autoimmune disease in the body. Like, for example, Sjogren's syndrome. It's associated with autoimmune thyroid disease. It's associated with so many other things also. And the worry about this one celiac is that I said in celiac histology there is a lot of infiltration of epithelial cells by the lymphocytes. So it can the lymphocytes can really proliferate and produce. It can take a malignant potential there. So they can have T cell lymphoma, in the T cell lymphoma, and also B cell lymphoma also in celiac disease. And some other malignancies like adenocarcinoma malignancies also increased in people having this thing, celiac disease. So always if somebody is wasting, just think, and it's just because of the thing malabsorption. It could also be because they have a malignant disease. So you always have to rule out a malignant process or malignant disease, especially lymphoma, in people having Crohn's disease, not Crohn's disease. Of course, Crohn's disease also. That will come to later on. Mainly celiac disease. Celiac means coelom. You all learn biology, no? It just means cavity. It refers to the abdomen. That's why it's called celiac. Celiac disease. Then the other disease process in the intestine is called Crohn's disease. We say it's an inflammatory bowel disease, just like ulcerative colitis. Ulcerative colitis, we all know, it affects the colon predominantly. But here, celiac disease can affect some part of the intestine also. This one, Crohn's disease. Crohn's, people think it is an exotic name. It's not an exotic name. It's named after an eminent gastroenterologist, U.S. gastroenterologist called Benjamin Crohn's, C-R-O-H-S, Crohn's, C-R-O-H-N, Crohn. Benjamin Crohn, he had actually a long innings. He lived about 99 years, 1894 to not 1894, 1884 to 1983, 99 years. And this is one of the contributions he made, Crohn's disease. But Crohn's disease is quite famous. So in Crohn's disease, the difference from ulcerative colitis is that it's a transmural inflammation. Transmural means it affects all layers of the intestine. whereas ulcerative colitis is superficial. It affects mainly mucosa, submucosa of the colon. Here it is a transmural inflammation, and also so it can produce what's called a stricture. The whole thing can become like a scar and produce stricture and a narrowing of the intestine and produce bacterial overload or intestinal obstruction and pain in the abdomen, like that. And there are three types. One is the stricturing variety, the other the inflammatory. Then there is what's called penetrating. Penetrating means it can break the intestine and penetrate into adjacent organs. That's called a fistulating or fistulating variety. So three varieties are, of which inflammatory is more common. About 50% will be inflammatory, about 15-20% is stricturing, another 20% is this one penetrating. So the Crohn's disease, again, diagnosis have to get a biopsy, and you can get a biopsy from the ileum from a colonoscope if possible, or you can give, but there is something, and nowadays there are two types of endoscope. One is called push endoscope. Push endoscope, you just keep covering a sort of thing in the near the ampulla of Vater, or this thing, the upper intestine, keep the upper intestine, and then from that through put a smaller tube called an endoscope. Put that, its diameter will be low. And then get a biopsy, and you can do surgeries, cauterization and section biopsy and all those things. That's called push endoscope. It's done by the gastroenterologist who's trained in doing it. And there is another called double balloon endoscope. So probably push endoscope may not reach the lower part of the ileum, but a double balloon endoscope you can get a biopsy for Crohn's. Of course, the gold standard for endoscopy nowadays is what's called a cordless capsule endoscopy. Capsule. It's a small like capsule, like a our ordinary drug capsule. It will be swallowed, and that will be radiographically followed. And the capsule has got camera, and it will take a large number of photos in the intestine. So and in magnification. So in maybe 3-4 hours they will get thousands of photos. So you can have a good check. It's supposed to be the gold standard, better than endoscopy. But of course you cannot take a biopsy and all those things with the push endoscopy. Another drawback is the capsule endoscope can sometimes get stuck. Then you have to probably remove it. There are some innovations to overcome that nowadays. I think. And so the Crohn's disease, this much. Crohn's produces bleeding. Crohn's produces a lot of difficulty, this thing, visualization to other organs, then intestinal obstruction. I can produce malignancy also in some cases. Concurrent malignancy can be there, not confined to intestine. Some other parts like cancer, lungs, and all that can be there in people having Crohn's disease. Then the treatment is just like ulcerative colitis, but especially in old people, the intestinal type of Crohn's is not that common. It's a colonic type. And also the perianal disease of colon in young people, seen in young people, Crohn's is not that common. Here, you have to always, inflammatory means you induce a remission, maintain a remission. Remission induction is usually by a corticosteroid. Corticosteroid, if it is a mild disease, you can use what's called budesonide. about 9 milligrams. If it's a severe disease, you can use prednisolone 1 milligram per kilogram and maintain it for some time. And of course, giving steroids can have so many deleterious effects, and some steroid sparing drugs can also be given, like methotrexate and immune suppressants. And monoclonal antibodies also there. If it does not respond to these things, steroids, can give monoclonal antibody. I don't know what mob is given. Some mob is there. Forgot the name. And then, so it's a chronic relapsing disease, Crohn's disease. So these are the things in malabsorption and of the small intestine. Celiac disease, this one bacterial overload, Crohn's to some extent, and of course pancreatic we would not consider here. Pancreatic is actually it's an exocrine deficiency. It's not malabsorption. So exocrine deficiency of the enzyme can cause some malabsorption of fat and all that. So then other problems are bleeding from the small intestine. Colonic bleeding is you can diagnose with the colonoscope, see with the colonoscope. You don't have to do an mesenteric angiography to diagnose colonic bleeding. The same way with newer forms of endoscope and capsule endoscopy. So it it has reduced the need for mesenteric angiography. But mesenteric angiography is a role in diagnosis. Of course, obscure bleeding, it doesn't have a role much. Mesenteric angiography. This one and endoscopy itself enough. You can find out from, and most of the causes are it's caused by lesions, this arteriovenous malformations. And in fact, and from small intestine, these are supposed to be what's called ectasias. I don't know what is ectasia. Ectasia means there is a thickness, not thickness, some large, it becomes bigger, these things without covering blood vessels, so easily damaged. That's I think about ectasia. There can be arteriovenous malformations, duolefoid, what's called duolefoid lesions. All these are possible. These are, there are two types. One is called occult. Occult means you can't find out where bleeding is from, but a patient will become anemic. Other one is obscure. Obscure is ear failure. Obscure means you have not diagnosed properly. So always do a colonoscopy, endoscopy twice before you say it is obscure. Occult. So when you do an endoscopy, through that you can cauterize also and stop the bleeding. Then the vascular problems is two types. One is the acute mesenteric occlusion. This is what people are afraid of. The high mortality, about 70 to 80%. People it comes with severe abdominal pain. Then later on abdominal distension, they will have acidosis, lactic acidosis, things like that. And nowadays with CT, the diagnosis may not be that difficult. Not do an angiogram straight away. You can do a CT or a CT angiogram with contrast and find that the mesenteric artery is occluded. When it is acutely occluded, it produces this picture, and there will be gangrene of the intestine. So you may have to do a second look after 24 hours to see what the viability. So again, treatment is here. It's most of the time it's caused by the embolus. It's like this. Embolus, 50% of acute mesenteric occlusion is caused by the embolus from the heart or from proximal blood vessels. aorta and things like that, and about 25% is from this thing, mm, what's called a non-occlusive mesenteric disease. That actually there is no clot or anything obstructing the vessel, but it has got a because of hypotension and things like that. You must have seen it in the peripheral also. Sometimes if you person has hypotension, they can have ischemia, like that. Then the blood vessel need not be occluded. So non-occlusive type is there about 25%. And 25% is because of in situ thrombosis because of the disease. So this is the acute mesenteric occlusion. So always have a when anybody, old people especially, it's more common in people having vascular disease, cardiac peripheral vascular carotid and things like that. And so acute this thing presents with acute presentation with gangrene and all things like that. But a chronic mesenteric occlusion, they'll present with what is called mesenteric angina. Mesenteric angina means 30 minutes after food intake, they will have pain. Then the pain will increase in intensity. Then it plateaus. Plateaus means it stays there for 2-3 hours. To such an extent that he doesn't want to eat much. So patient will have a lot of wasting because he is not eating. But that's called sitophobia. SITO, sitophobia. Sitos means food. So sitophobia. So they will have sitophobia, and then the chronic mesenteric occlusion is just like chronic vascular disease. So the treatment is, if the treatment for acute is giving a vasodilator and sometimes do a thrombectomy and all that. Here the treatment is endovascular or open vascular reconstruction. So, but generally they will have 2 mesenteric arteries occluded before getting an intestinal angina or chronic mesenteric occlusion. Sometimes all 3 are occluded. Still, they will just have angina, but not the thing. Mesenteric is, the intestinal infarction, intestinal gangrene may not be there. Because there are a lot of collaterals, even if all the 3 are occluded. But more common is 2 vessels are occluded. About 50% of cases 2 vessels are occluded. So you can reconstruct. In old people, it's possible to do it even by endovascular means also, by putting in a stent there. With little experience in this kind of thing. Of course, we have sometimes come across this one, but poor prognosis. But I'm sure there will be some vascular surgeons who are doing all these things. Okay, the last part of intestinal disease is the intestinal malignancies. Primary or secondary? Secondary is mainly from melanoma, intestine, the small intestine. The small bowel, main secondaries for the melanomas. Then there you have benign tumors like lipoma, and one more is there. What is that? The usual stuff, But they'll present with can present with this one intestinal obstruction. And melanoma, then what is that? Anyway, but benign, if it is less than, I'm not talking about lipoma, maybe I'm talking about some muscular tumor. If it is a benign muscular tumor, what is that called? Benign muscle tumor, mesothelioma, is it? Maybe. It is sometimes called but this is different. Gastrointestinal stromal tumor. Stromal is actually uh, kind of sarcoma. Stromal tumor is a kind of sarcoma, but all are not malignant. Less than 2 centimeters in size need not be malignant. But larger ones you have to take it out of biopsy. So the more common, the commonest is then again adenocarcinoma in the intestine. Adenocarcinoma is usually seen in, it's our periampullary tumor, duodenal that area, duodenal upper GI. There's a adenocarcinoma. That is supposed to be common. Then there is another called carcinoid tumor. Carcinoid tumor is after adenocarcinoma the commonest tumor in small intestine. Of course, lymphoma comes third. So carcinoid tumor is it produces what is called as the thing, it produces serotonin, a lot of serotonin. It produces flushing, and then it produces sometimes breathing problem and some heart failure and things like that. And it is generally very difficult to diagnose. Of course, CT scan, if it is large enough, you can abdominal CT or what is called CT enterography or MR enterography. You might see the small tumors, but generally where you may have to resort to some kind of scintigraphy, like somatostatin. It's called somatostatin scintigraphy. Somatostatin scintigraphy can bring out the carcinoid tumors. So carcinoid tumors prognosis is not that bad, even if it's very advanced, like having metastasis in the liver. There are some kind of resection. Liver resection can be done, and then you can give drug is there. Octreotide can be given. Some chemotherapeutic agents still can be there. And how you diagnose this, there is something called 24-hydroxy this one, indole acetic acid. 24-hydroxy indole acetic acid. That will be high level. That's a serotonin product. So serotonin, that means a lot of serotonin is produced. Plus the abdominal symptoms and generalized symptoms, you say carcinoid, you happen to get an imaging tumor, or you get a biopsy, endoscopic biopsy, then a carcinoid tumor. Endoscopic biopsy very rarely can be taken of carcinoid tumor. Then the lymphoma, but B cell and T cell is there. But T cell is associated with this one, our celiac disease, T cell lymphoma. And you can resect it, you can give chemotherapy. And by the way, all these things, it's not like in other areas. If it's confined to intestine, if you do a resection, the 5-year survival rate can be about 50%. Not bad. So then the terminal ileum has this thing, it's a place where it absorbs the bile salt, also absorbs vitamin B12. So if the terminal ileal disease there, or terminal ileum is resected, like when you are doing a hemicolectomy or for some other reason, then they can get what's called bile acid diarrhea. It's somewhat like malabsorption, because the thing is not the thing, bile salt and acids not reabsorbed, forming the enterohepatic cycle. So it will be more there, and it produces diarrhea. It will not, this bile salt is required for absorption of fat. So fat will be there, a lot of fat will be there, unresolved, and so it can lead to diarrhea. That's called bile salt diarrhea, bile acid diarrhea, diarrhea. And nowadays there's a drug called cholesevelam. There is a drug called cevalum in this thing, phosphate binder is there. Phosphate binder for kidney failure, probably related to that is cerebellum or cevala, I think, something like that, cholesevelam. So it is a bile acid sequestrant. That's supposed to be a treatment. But B12 deficiency can be there. You have to give B12. How you diagnose B12 deficiency is B12 level. You have to have a high B12, low B12 level and a high folic acid level to diagnose this thing, B12 deficiency. And B12 deficiency produces megaloblastic anemia. Megaloblastic anemia is also associated with not only with anemia, it can cause leukopenia and thrombocytopenia also. Peripheral neuropathy. So like that, maybe quite common in old people. This is a short take on, short take but a long time, about 35 minutes I think, of small intestine. You think it is short, but time just flies. Thank you.